It's completely a branding issue. Yeah. The first striking thing is people just listen to you. So, sitting in clinic, and I was finding it difficult to sign my name to something that I'd written in the notes.
Yeah.
Because everything right. I will make decisions that other people will disagree with, but also I think a part of it is you do have to back yourself a little bit and go, right.
Hello, and welcome to another episode of this podcast. We have with us today Dr. Sohel Samad, who is a consultant anaesthetist and one of my colleagues. Welcome to the show, Sohel.
Thank you.
Great. Well, the idea behind this conversation really is to try and help ST6s, ST7s, not just in anesthetics, but maybe even other specialties, see how they can not just prepare best for their consultant interview, but also life as a consultant. So a bit of before the interview, during the interview, after the interview, what's the differences you perceive as a senior registrar back then versus how you are right now, and what things you found new as a consultant. So let's dive in first with, just before we started, you were talking about preparation for your CCT or just after your CCT for your consultant job. So what was that you were talking about? What sort of preparation were you referring to back then?
So I think it's about having an idea of, I think once you're getting towards ST6, it's about knowing where you want to work and what you want to do when you're CCT. So it's thinking about whether you want to be in a DGH, whether you want to be in a tertiary centre, and starting to gear your CV and what your special interests are going to be towards that. If you're going to want to do something that's tertiary centre, then you're restricting yourself a lot more potentially to which hospital you're going to be able to work in. So then you need to really speak to that hospital and go all in on that hospital and that location. You know, for example, if you want to do transplant surgery and you want to be a transplant anaesthetist, you need to, at ST6, start thinking about how you're going to do that, because your only option is going to be the transplant centre. So you've not got the option of different hospitals. So you've got to really gear yourself and your CV towards that speciality. And you've also got to then consider that you're most likely also going to have to do an SCF or a additional fellow training potentially to get yourself prepared for something that's really niche like that. Or whether you want to be in a district general hospital or a slightly smaller hospital, where I think you then need more potentially transferable skills and thinking about things that are more useful in a DGH. So it's starting to think about which level of hospital you want to kind of work in.
So what did you, so personally speaking, I mean, this issue of DGH versus a tertiary hospital is probably lifelong. And I've been a consultant now for about 10 years. And I think we used to have these discussions about DGH versus tertiary centre. And I personally started with this high ambition of wanting to work in tertiary pediatric centre. I got shortlisted for about 2 or 3 different jobs, got interviewed for 2 or 3 different jobs at these tertiary centres, didn't get them probably because my experience was a bit misaligned between what I liked doing, which is retrievals, and working in theatres back then. But anyway, yeah, so that discussion, Did you think about it, or did you have it early on in your career that you wanted to work at a certain place and you kind of went for it, or did you want to keep other options open?
So I always knew I preferred working in a DGH. So there's a couple of reasons for that. Firstly, I think what can happen in a lot of tertiary centres, and it's not exclusive everywhere, but is you kind of almost get pigeonholed into doing a certain list or a certain operation or a certain area, and you just do that over and over and over again. And because it is a tertiary centre, you'll often have different consultants doing different on-calls. You know, you will have an obstetrics consultant doing an on-call for the obstetrics. You'll have a paediatric rota. You'll have a general on-call rota. If it's a neuro centre, you might have a neuro rota. So therefore, if you're a general consultant, you are only really covering the general theatres. Whereas in a DGH, if you're on call, you're covering everything. You're covering peds, you're covering obs, you're covering the general stuff. So therefore, I always like the idea of being able to still do everything rather than just being a kind of niche, narrowed down kind of speciality, which I know some people love, and that's why they love working in a tertiary centre, and that's great. But for me, I liked the idea of being able to kind of do a bit of everything and keeping my skills up in all kind of different areas.
So would you say wide rather than deep?
Yeah. Exactly. Yeah. Wide, but with deep interest. So, which is what I have now. So I feel I've got, a very nice mix where I do a bit of
Yeah,
everything, but I've got a deeper understanding and a deeper interest in vascular and regional, but I still do
yeah.
everything on my other days.
So just for a second, let's talk about that niche example you gave about
Mm,
transplant anesthetists. I mean, that is
yeah.
like really, really niche, isn't it?
Yeah.
I mean, do we know not a lot of people who go into that, or any other example for? I mean, I see your point when you say that,
Yeah.
especially coming to like cardiothoracic, for example,
Yeah.
you'd have to have a fair number of things stacked up in order to be even thinking about applying to one of those institutions.
Exactly.
Did you ever think about any of that side of things, like going really deep into one aspect of anesthesia?
Yeah, I did actually. When I did ST3, when I was ST 3 or 4, in that region somewhere, when I did my neuro rotation at Adam Brooks, I actually really enjoyed it. So I really, really enjoyed neuro. And I did think about doing neuro. So I thought about, following that kind of pathway. And Adam Brooks, for
Hmm.
example, has a fairly set pathway. You have to do an SCF, but, um, doing a neuro speciality, doing a neuro subspec and going down the neuro pathway. But then the more and more I found out about what the consultants were doing and what their kind of life was like, again, I just realized it was then all in on neuro. So there wasn't a huge amount of opportunity, unfortunately, to do a lot of anything else. And whilst I really liked neuro, I didn't just want to do neuro for the rest of my career, effectively. So again, it just came down to that thing of actually, if I just did neuro, I wouldn't get to do any regional, for example. I wouldn't get to deal with a lot of the other stuff that I enjoyed dealing with. It would just be neuro anesthesia every single day, which is interesting and has lots of different aspects to it. And that's why I liked it. But I didn't want to just do neuro every single day. I could just imagine that it would be fun for a couple of years,
Yeah.
but then I might lose interest in it
But that's obviously that's a personal thing
completely.
that's
Yeah.
coming across
Yeah.
as you. I mean, do you know anyone among in your cohort who went ahead and did neuro or cardiac and they really love it? I mean,
Yeah.
what's
Yeah.
just worth wondering and talking about? What's the difference between um, someone like you who wants to have a wide breadth of things and someone who wants to go really deep into it? It's not intellect, obviously, but,
Yeah.
is it different personality types? What do you think is a factor?
Yeah, I think so. So there's a colleague of mine who I did my finals with, and he's now a neuro consultant at Adam Brooks. He's again, we trained together, but then he fully went it down the neuro pathway because once he did neuro, he just found it really interesting. And what he wanted to do was he wanted to become more and more proficient at anesthetizing patients for neuroanesthesia. He just wanted to get better and better and better. And he wanted to very much be a expert at that one area so that when it came to anesthetizing patients for neuroanesthesia, he wanted to be as good as he could be and go all in on neuro because to him, there was always different aspects of it that were interesting. So doing the different types of cases, having, coming up with new, different, interesting ways to anesthetize the patients, wake them up, managing those major hemorrhages that you do still have in neuro, all of those things. So there was more than enough interest in neuro for him to go all in. And it's the same with
Yeah.
cardiac. So I've got, again, a similar friend who went all in on cardiac because for him, again, it was all the different aspects of being able to manage the ITU and having the kind of excitement of kind of transplants on pump, off pump bypasses. So there was a lot of different aspects in there and it allowed him to do echoes and it was very procedure heavy. So all of those aspects were very interesting for him to be able to go, actually, do you know what? I'm an absolute specialist in that one area. And both of them didn't really have interest in doing anything else. So they didn't have that broad
Yeah.
interest that I do, where I actually like doing other things. They were quite happy to never have to see an obstetrics theatre again or
Yeah.
ever have to see an ENT theatre again or anything like that. So they were perfectly happy. And for them, that's what's
Yeah. I identify with the obstetric part of their thinking.
I think a lot of people probably do.
So coming back to you then. So what was your SIA?
So my SIs were, again, and I think this is coming back to thinking about where you want to work. So when I did my ST5, I think it was end of ST5 at the Lister, I really enjoyed it and it suited me for where I lived. And also yes, there's a DGH, but it's a very busy DGH and we do a lot of stuff actually that's very interesting. So I knew I wanted to have a good chance to work there. So I spoke to the CD at the time and asked what she would need in 2 years' time for an anaesthetist to be able to do. And at that time, the procedure room was planned to be opened and the hybrid was planned to be opened as well. And I mean, it was convenient that they're the two things I wanted to do as an SIA anyway. So it worked out very well. And I think that's part of it. I think at the time, it probably showed that I was fairly committed to wanting to work there because I was targeting my SIAs to be competent at the things that they would need in a year and a half and 2 years' time, which was going to be people who could do regional anesthesia and people who could do vascular anesthesia. So I think that was, for me, that was part of the planning of going, actually, my SIAs are marrying up nicely with the place that I want to work in and the requirements they'll have in 2 years' time.
Yeah, but that was, I would say, a little bit lucky in that you got lucky with the timing of both those things were evolving at that time. I often get asked this question about what is it that you're going to be looking for in, I don't know, 2, 3, 4 years' time. And I find it hard to answer that question. And my advice usually is to go out and do what you want to do, because that's the sort of thing that if you like something, you're going to get really good at it because you like it, not because I've asked you to do it. I'm guessing between vascular and regional, they were the sort of things that you already liked.
Yeah. So regional I've always liked because I've done it since I was a CT1. So I've always been fairly heavily involved in regional. And vascular was something I picked up later on because it kind of stemmed off me writing that course with the college, because then everyone kind of just started saying, well, you've written this vascular, it seems silly for you not to be a vascular anaesthetist. And actually, the more I did it, the more I found there was a lot of transferable skills in vascular. You know, it's dealing with major hemorrhages, it's dealing with sick patients. And actually, I started finding it quite interesting. So I kind of fell into vascular, but it worked quite well because I quite liked it. And I thought it had a lot of very transferable skills of dealing with sick people, dealing with blood loss. And it also married really well with my regional anesthetic, because it meant with my regional, I could then anesthetize a whole load of high-risk people with blocks, which then didn't need spinals and didn't need GA. So it gave me a whole new way to anesthetize people.
So what if back then, and this is a challenge to you, what if back then the then CD had said, we need an obstetric anesthetist? Would you have gone into obstetrics, or would you have pursued what you wanted to pursue? I'm presuming you're not in love with obstetrics.
No. So I don't mind obstetrics. I think like some people really hate it, but I don't have a problem with that. I don't hate it. But would I have done obstetrics as an SIA? I wouldn't have done, because my interest would have still been in regional and vascular, and they were the two that I would have wanted to do. So I think, again, it goes back to what you were saying. I think there's certain things that you do a lot of anyway. Obstetrics, you do loads of obstetrics in training, and yes, the SIA does improve your skills in obstetrics. But I guess if it then came to being obstetrics, I always had it in my mind that I felt I'd done a lot of obstetrics in training, and hopefully I'd be able to have enough skills to be able to step in and step up and cover it. But I wouldn't have changed my SIA. I think I would have still done vascular and regional. Because again, I think it's a lot of
wanted to do, or what you liked, basically.
What I liked, yeah. Because like you said, I think it's important to do what you like.
Yeah.
You've got to bear in mind what's needed, but it's also important to do what you like.
Yeah. So that was about the clinical bit. And you also have a few other interests outside of the clinical work, which you were quite heavily involved with whilst you were a trainee. So tell us about that side of your CV, for lack of a better expression, about where you were doing your teaching roles within the deanery, and I think some nationally as well, or correct me if I'm wrong.
So it sort of started in ST4, where I did a fellowship. And so I went part-time in my training and did a fellowship in virtual learning or blended learning. And I basically created a e-learning course working with the VAS GBI and the Royal College on vascular anesthesia. So I worked with the VAS GBI. So obviously I was in the ST4 at the time, so I didn't write huge parts of the course, but I got the experts to write it, and then I collated it all and put it into an e-learning package. And I did that for a year and a half as part of the fellowship. But then after the year and a half, the person who was running the fellowship then moved on. So there wasn't anyone to run the fellowship. And as my project had been the most successful and kind of standout one, I was asked if I wanted to take over running the fellowship for the subsequent years, which I then did. So I then ran that fellowship And then as I ran the fellowship, I started to become more involved in the organization and running of the region's virtual learning, basically. So then I was given the job of being a senior fellow and running all of the training and education, basically, alongside the associate dean and the deputy dean. And then,
So sorry, this is senior fellow of what?
So I was so my official title was a senior blended learning fellow, but it was basically just for the job that I was already doing, but it was more, I needed a title because I was using, because I didn't want to extend my training, I was using my study leave and my EDT time to do that role in agreement with the college tutor.
And this is as ST?
So this was from ST5 onwards, really.
After your finals?
Yeah. So I finished my finals and then I did this role kind of alongside my training.
Mm-hmm.
And then once I finished training in CCT, they obviously couldn't keep me on as a fellow. So then they gave me a role as a training program director for
So you
learning.
carried on doing this throughout ST5, 6 and 7?
Yeah, pretty much for the whole 3 years. Yeah.
So who was your employer at that time from the learning side of things? I mean,
yeah. So from the learning side of things, it was East of England. So NHS East of England. So the East of England Deanery was
East of England. Okay.
Yeah, so they were my
Fine.
employers.
And then, so all of that, how did you develop an interest in that? Did you always want to go into something like that? Were you into tech? Were you into education? What were you into?
So I was very into education. I wasn't necessarily into tech or e-learning, but I've always been very involved in education. So I've always done teaching. I've always had teaching roles. I've always kind of developed teaching programs and done a lot of teaching, sim, etc. And this was more just an opportunity that came across when I was at Adam Brooks. The post was advertised and it seemed quite interesting because I got to kind of create something. And at that time, there wasn't much out there in terms of virtual learning. East of England were very much ahead. They were quite ahead of the rest of the country in terms of the content and how we taught virtually. So it was quite a up and coming area with a lot of interest. And I saw a lot of potential for what we could do with it. So therefore I thought actually it's something that is quite interesting and it allowed me to do something alongside my clinical work that I found interesting and sort of could get my teeth into. So therefore I thought actually it would be a really good way to do something I wanted to do, but also, from a selfish point of view, develop my CV because I knew it would have opportunities for me to develop my CV as an educator, which is what I wanted to do alongside my clinical work. So it was a lot of that kind of made me or kind of encouraged me to do it really.
So was it mostly self-driven then?
Yeah, I would say so, yeah, because I saw the opportunity and I wanted to do it. And I think that was part of the reason why I was kept on and given more senior roles because I think I was incredibly driven to kind of do what I wanted to do. And I saw the potential of what we could do with it and kind of encouraged a lot of people along the way to kind of do what I was doing, if that makes sense.
So you didn't really have to do it then. And if I'm just playing devil's advocate, you could have coasted along. You passed your finals. You could have coasted along ST5, 6, 7, done your SIAs, applied for a job. You'd probably still have got the job, or someone would have employed you with your skills and and everything you can do. So I'm just trying to bring out this thing about why people do the things they do that kind of go above and beyond the prescribed curriculum, as it were. Because I find that with residents, upcoming generation of doctors, sometimes I struggle to explain why. Actually, that's not true. That probably happened in my time as well, to be fair. There's always people who want to do things and people who not, they just want to do what's prescribed and move on with things. They might have other interests. So, but in your case, have you always been the sort of person since school who wanted to do something else, or is this something how did you go about doing it?
So yeah, I've always done extra things. It's always been, I think part of it is, I think part of it is, I don't know, maybe it's my nature or how I am. I've always been nominated or pushed into like leadership roles and management roles. Even at med school, I didn't want to be the medical society president and I ended up being the med society president. In F1, I didn't want to be the MES president and I got nominated to be the MES president, ended up doing the MES presidency. So I've always been in those roles and I've enjoyed them because I think it's a nice balance between having the clinical work, but also having something that you really enjoy and find interesting that allows you to kind of switch off from the clinical work. And I've always enjoyed that.
in the way you've just presented it, I find a bit of a paradox because you've said that I got pushed into it
Yeah.
and I got nominated as something,
Yeah.
but then you ended up saying I really enjoyed it.
Yeah. Yeah.
And this seems to be happening again and again throughout your life. So there there has to be some sort of a personal drive to it as well, right? I mean, it's not just other people pushing you into it.
Yeah.
You must want to do it, and you must enjoy. Well, you said you enjoy doing it,
Yeah.
but there has to be. I mean, it's not a bad thing. It's the sort of thing which is good.
Yeah. I think part of it is, I think when I'm given stuff, I think I do it well, is what I would say, because I don't like doing anything badly. So if I'm given anything
Yeah.
to do, I think I've always demonstrated that I do it well. So then if I do it well and I do it reliably, then inevitably the people above you then go, okay, we need to keep you on, or here's some more responsibility because you're doing this bit well. And then it kind of then snowballs,
Yeah.
because as you get more responsibility, you get more ownership. So you get to control more things, and kind of, you get to do it in a, you know, you get to kind of shape it how you want to shape it. And you start
Yeah.
then enjoying it more, because you start realizing you can actually make a really big difference. You know, even for me, I've gone from being a fellow at ST3 to now the associate dean within a year of being a consultant, and now working with the national platform with the TEL team to guide how we're going to develop virtual learning for the entire country on this platform. So all of a sudden, I've gone from creating one course to now I get to have a big influence on how we run virtual education for a huge number of trainees. And it's fun trying to make it better for people and trying to improve what we already have, and kind of develop it so that it's something that becomes really organic and something that's really useful. So I think that's quite enjoyable.
So all of this is obviously the nicer parts of the story. So have there been any disappointments, any failures along this education journey?
The education,
or anything that springs to mind? Yeah, we can come back to it later on.
Yeah. I guess in terms of the education journey, I think there's definitely been, there's been points where I've probably been kind of in roles, and I haven't, you know, in these these high roles, and I maybe haven't understood exactly the depth and scope of what's required, or perhaps, you know, one of the things, I think we were talking about buying a piece of software that I had a look at and I thought would be good, and we ended up spending a bit of money on it. And then actually when we got it and we applied it practically, it just didn't work and it wasn't useful. So, you know, that was funding wasted effectively, because we kind of had it for a year and we didn't make great use of it because it didn't quite do what we wanted to do. And again, my learning from that was actually I probably underestimated how much my opinion would be taken in kind of acquiring that piece of kit. So then all of a sudden...
So you got taken more seriously than you thought you would.
Exactly, because I thought I was only ST6 and you know, no one has ever really listened to my opinion. But then all of a sudden my opinion was being very valued. So my kind of learning from that was, actually, if I'm asked my opinion on things in the future, I need to really look into it properly before I give my opinion.
So obviously all of this helped you in your consultant interview, and I'm actually thinking we'll come back to the consultant interview at a later date maybe, and talk at length about the interview. But I think there's a bit more to it beyond the interview, which is life as a new consultant. So how easy was it for you to, when you started as a consultant, did you already know what programmed activities are and PAs are and how life is designed around PAs? Did you know all of that, or did someone explain it to you?
So I had a good understanding, but I think, again, that's because I was very proactive about finding out what the job plan would be like. So I spoke to a lot of the consultants at Adam Brooks as to what the work-life balance was, not work-life balance, what the PAs was, how many hours they had to do, what the on-call requirements were versus the lister, as to what the job role was there, what the on-call requirements were there. And I think, having been at both those places as a senior registrar, I got to speak, you know, frankly, to a lot of the consultants. So I knew what the job role was in terms of how many PAs I had to do. I probably didn't realize how those PAs would be divided in terms of, you know, SPAs, for example. I didn't really understand SPAs and how SPAs worked and what SPAs were for. I got the clinical PA aspect of it, but I probably didn't have a clear understanding of the SPA aspect of it. And then I didn't really understand how the PAs for on-calls, for example, would work and how they would be all kind of set out. So I knew what days of the week most people worked, but I didn't probably understand where the on-call PAs and the on-call supplements, etc., all those extra bits, where they all kind of factored in. But again, I think it probably comes back to more a little bit. I had to look into it more because I knew as soon as I CCT'd, I would be having to fit my TPD role as 2 PAs into my job plan. So I had to look into it earlier to make sure that I could fit the 2 PAs into my job plan, because obviously, say if I'd gone to Adam Brooks, how I fitted those 2 PAs in would have been different to how I do at Lister, for example, because at Adam Brooks, their normal consultant rota is like 11.8 PAs or something. So I'd have had to drop some clinical work from the offset to fit my TPD PAs in, whereas at Lister, I'm able to add them on top of my clinical work. So I had to probably be a bit more proactive because I had to know those things before I applied for the jobs effectively.
So your education role didn't just help you with it just helped you overall in life, adapting to your new role as well. So what would you say was the biggest difference you found when you first started as a consultant? Life as a resident, life as a consultant, you rock up to work, 8 o'clock, you start seeing your patients.
Yeah.
Does anything strike you as completely different, or is it just continuation on the same spectrum without, not a lot of things changed?
No, I think it's definitely different because all of a sudden the first striking thing is people just listen to you. So, like when you're a senior reg, I was a senior reg at Lister or at Adam Brooks, but even on a daytime list, everyone's like, oh, where's your consultant, or who's a consultant for this list? Or you come up with a plan and they go, oh, is that what the consultant wants to do? Or is that what you want to do? Like, whose plan are we following today? Whereas when you become a consultant, like my first case was a carotid as a consultant. And I was like, right, okay, we'll do patient's fine. We'll do it as an awake carotid. There's no, oh, are you sure you want to do it awake? Should we do it as a GA? Should we do this? I was like, no, we're doing an awake carotid. I want an outline and I like a big drip. And this is what we're going to do. And everyone goes, okay, cool. We'll get all of that ready. Great. There's no, like, not in a bad way, but there's no, because obviously you're making a sensible decision. I expect pushback if I'm making a ridiculous decision or something that's completely stupid. But if you're making a sensible decision, all of a sudden it's like, okay, yeah, cool, we'll do that. And there's no pushback. And even the surgeons treat you differently because, 4 months ago, so obviously I started at Lister 6 months before I started at Lister, I was a reg there, but all of a sudden the surgeons treat you differently because they're like, we're doing this case, what do you think? And I'm like, okay, yeah, I think we should do this, or we shouldn't do it. And they just seem to value all of a sudden they value your opinion and your advice a lot more than they did even, say I continued in the day before.
So what you've said is that the thinking and the outlook of everyone changes, right? From the scrub staff to your own colleagues to surgeons. Do you think it's a branding issue, or do you think, come on, overnight you can't have changed from being stupid to being extremely mature?
Yeah, it's a branding.
That makes me want to say, is it a branding issue?
It's completely a branding issue. Yeah, I think if you stuck a consultant tag on a lot of senior registrars in their last 2 to 3 months, they're a lot of them are ready to be consultants in the last 2 to 3 months. It is completely a branding issue. The second you stick the name consultant on you, all of a sudden everyone's attitude changes towards you. Even if you were the best senior registrar in the world, you're still a senior registrar, and all of a sudden I found it funny. It's at the Lister, for example, like consultants who are much more experienced than me asking my opinion on things, and
but that's a bit different because I've always said that as ST7 you're probably at the peak of your performance, and it's all downhill from ST7. Well, it's downhill in most areas except the areas that you regularly practice, and then in those areas you get really, really good. Okay, so that's the question of perception on there. And how do you feel then? As obviously you were quite happy to be in that position where everyone just listened to you. Do you think other people might find it a bit intimidating? Or like really surprising? What would help before? So I've got my CCT yesterday and today I'm a consultant. Is that a good transition, you think?
So I think it depends on firstly, how comfortable you are in a leadership role, because I think as consultants, you are seen immediately as a leader in regardless of whichever speciality you do. So I think part of it is how confident you are and how comfortable you are in leadership roles. And part of it is also how comfortable you feel clinically. So I found the transition from being a registrar to a consultant not difficult, but that was because in the last 6 months of my training, I very much sat down and identified things that I wanted to tick off in my final 6 months of training that I felt I really wanted to tick off before I became a consultant, because they were the things that scared me. So I wanted to do, in my last 6 months, for example, I did some extra peds. I did some more open AAA repairs, because I was like, actually, these are the things that I really want to make sure I'm really good at as a trainee.
So when you said tick off, you don't really mean literally tick the box. You mean
No,
actually do them
exactly.
and get confident and comfortable
Exactly.
in them.
Because
Yeah.
I'd
Fair enough.
already ticked the boxes for those. So they were already signed off. It was all done.
Yeah.
As far as my competencies were concerned, it was all done. But within myself, I was a bit like, actually, these are really things I want to really, really be good at and be doing on my own as a registrar with a consultant in the building somewhere, but not even in theatre, because this is going to be what I'm supposed to be really good at and what I need to be able to do as a consultant. I don't want to turn up as a consultant, do my first open AAA repair and be like, oh my God, this is the first one I've done on my own. So I was very adamant that I had to be good at those things on my own. And the same with, regional. So I wanted to be confident that I could do awake regional surgery as a trainee, because I didn't want to all of a sudden be a consultant and do my first awake block as a consultant with no one watching me. So I made sure that I did them on my own. So I think that made the transition a lot easier.
So obviously you had the insight and foresight to see all of this, and perhaps even the confidence to accept and understand that you are probably, these are the areas that I lack in. Yeah. What can I do to get better at it? What would you say to someone who is an ST7, let's say, and let's say they have a slightly, a shy personality, as it were, and they're a bit hesitant about doing things clinically, like lacking that bit of confidence in themselves to actually go out and do it and have that thing in themselves. What is it that they can work on themselves to develop themselves from where they are to, let's say, where you were at ST7, where you went in with, it sounds like you went in with the conviction to say, I can't do this. Let's take the example of awake blocks, right? So it's almost you can think of it as a high stakes game, because you can be like, if I fail this block, this patient cannot have the operation and will need a general anesthetic. And in this place, this particular theatre, we don't do general anesthetics, which means the operation is going to be postponed and it's all going to fall upon me. So there's a slight element of risk involved with that. Taking that risk, what's your thoughts on that? Should you, shouldn't you? Obviously you did. And what did it take to take that risk? And any suggestions for, our colleagues who are maybe in that position?
Yeah. I think part of it, I guess, for me personally, was I was given the confidence by the people who were training me at the time. So they gave me the confidence to go, you can do this on your own. You don't need us here. What's good for your training now is to actually just do these on your own and figure out your own way of doing it, figure out what works for you, because you've seen all of us do it. So I was given a lot of that confidence to go, actually, do you know what? You're just going to be on your own. You just get on with it, because actually we trust your skills to be able to do this. If you need us, we're there, but you just get on with it and do it all on your own. And I think that gave me the confidence. And then when I started doing it on my own, I then got the confidence that actually, yes, I can do this. I'm able to build on what I've been taught, and I can do this on my own. I don't need someone kind of there guiding me through it. So I think that helps. But also, I think a part of it is you do have to back yourself a little bit and go, right, actually, do you know what? I'm just going to make this work, and I'm going to do this because I've done this 20, 30, 40 times, or however many times you've done it before, with someone watching you or being around and just going, actually, I've got the skills to do this. I know I can do this. So now I just need to back myself to do this. And doing it as a trainee in that situation is the perfect way to do it, because you can back yourself to do it, knowing you do still have a backup if you really, really need it, which is the consultant that's there. But you just have to back yourself that you can do it. And most trainees can, by the time they're getting towards that ST7 stage, they just need to back themselves to do it. They just need a push to go.
So believe in themselves.
They just need to believe in themselves and just have that push that they can do it.
Yeah. But some people don't believe in themselves.
No.
What can they do, you think? I mean, I don't know the perfect answer to
Yeah.
this. But I agree with you that you do need to have that extra bit of, call it faith, call it
Mm,
confidence, to literally push through that little bit extra that's gonna get you through that wall and give you that confidence to go out and function independently. What often stops them is the fear of failure,
mm,
the fear of getting a bad reputation, the fear of other people, including your consultants, supervisors, thinking that they're going to think I'm crap at this. I mean, have you had any experiences like that? I suspect no, because you've been, if you've been, it's almost like you've been on that track of where one thing's led to the other because you have believed in yourself and you sort of got on with it. But I don't know if you've come across any other colleagues, senior, junior, contemporaries who've been in that position. I see it from time to time, and I just think about how is it that they can help themselves.
yeah. I think part of it is, and I had it, is one of the things I had, I think, when I started as a consultant was one of the bits, although I found it a lot of aspects okay, one of the bits I did find difficult was doing the high risk anesthetic clinics because you're making decisions for other people a lot of the time. And I was finding it really, really difficult owning my decisions. And I was worrying about what other people would think about a patient that I said was fit for surgery because my threshold for what I might investigate for would be different to someone else's. And I think what really helped was just accepting that you're never going to please everyone and that I know I'm never going to get everything right. I will make decisions that other people will disagree with, whether as a registrar or whether as a consultant. And I'll have days at work where I've done a good job and I'll have days where I do a bad job. Not intentionally, but those days happen. And I think I decided quite a while ago that how you can't, and I'm the same with anyone else that I meet, you can't make decisions on someone's skill on a single event. It's always repeated patterns. So just because a trainee has had a bad day with me, that doesn't mean they're a bad trainee. It probably just means they've had a bad day because there could be 1,000 other things that happens for you to perform badly on that day. And that's how I always looked at myself. So if I've had a bad day and someone's given me really bad feedback, I've taken on board the feedback that they've given me and gone, right, okay, where could I have improved? But that's where I stop. I don't take it as a personal attack of them thinking I'm a really bad doctor. I think of it as, okay, I've turned up today and I've had a bad day at work and I've not done X, Y, and Z correctly. And they've said, I've done X, Y, and Z incorrectly. What can I do to make sure that doesn't happen again? And that's where I stop. I don't think, oh my God, if I turn up tomorrow, they're going to think I'm utterly useless or they're going to think I'm utterly hopeless because I'll be a completely different person tomorrow. And I know not everyone's the same. Some people do very much hang on to that first opinion and struggle to change that. But I've never thought of it in that way. I've always just thought, start every day as fresh. If you get bad feedback, you get bad feedback. You take on board what they've said, improve where you can. But that doesn't immediately, one person thinking you're bad at your job doesn't make you a bad doctor. You're still a good doctor.
So have you had any bad feedback as a consultant?
As a consultant, I guess in terms of, there've been bits where I've not there's bits where I think after one of the vascular procedures, I forgot to document the blood pressure targets. Again, mistake I made. So now I'm.
No, I mean, real bad feedback, not that kind of bad feedback. That's the sort of I saw someone else make a mistake kind of feedback.
I guess I haven't so far. I'm sure that will change.
Okay. Yeah, no, that's fine. I mean, yeah, as you say, it will happen at some point,
Yeah.
but yeah.
I guess.
Well,
yeah.
Go on.
No, I was just saying, I guess things that I know that maybe I've not had bad feedback on because I've already worked on is particularly how I run a theatre list. I know that I turn up and I work at a very rapid pace. And I realized early on when I was a reg that not everyone can work at that same pace, and actually working at that pace can stress people out and it can make them, they can't work at that same pace, and that's fine. So I've realized quite early on that actually I have to have a much more collaborative approach with the theatre team in terms of what I'm trying to achieve and how fast I want to work and what I want to get done and pushing to get the next case in, etc. Those kind of bits. So I think that's really, I changed how I did that quite early on as a reg. And I think hopefully that's translated into with me being a consultant in that actually I work a lot more collaboratively probably with the theatre team than I think I would have done 2 years ago.
So you say collaboratively, but as a consultant, you find there's more of a power gradient between you and the rest of the team?
Yeah, I think there's always going to be. I don't think you can avoid that because I think despite the number of times I've told people to call me Sohel, they still call me Dr. Sohel. And I think there's always going to be a power gradient, but I think you can do a lot to reduce that. You don't have to be a dictator. And I think the way you approach the theatre team and the way you approach to the staff and speak to them and can go a long way towards reducing that power gradient so that people do feel
Mm.
comfortable coming to talk to you about things and concerns, etc., etc. And it can be much more collaborative. And I personally prefer that approach to working than a kind of, I guess, commanding role, dictatorial role.
Do you ever feel isolated working as a consultant?
Yeah, I think you can do. I think you can do. I think that's one of the nice things about where I work because I don't think I feel isolated where I work. And I think that was probably a big reason for why I chose to work where I work, because I think when I spoke to consultants from other hospitals, they did say that particularly as an anaesthetist, they can feel quite isolated because you're kind of on a list. You're just doing those lists. You might not necessarily see or speak to anyone in the other theatres or, in the collaborative coffee room or anything like that. Whereas I think we are lucky where we work. I think it is very collaborative, and I don't, I've been there a year and a half now, and can't say that I feel particularly isolated. I think there's always someone coming in to check how I am, or coming in to give me a break, or just to catch up, and you have nice dialogue with the surgeons as well, I think, where we work. So I think through that kind of thing, I don't particularly feel isolated, but I completely can see where some people would feel isolated, potentially depending on what kind of list they're doing and what they're doing.
Cool. Is there anything you wish you'd known before you became a consultant that you didn't know, or that would have helped you be in a better position than you are at the moment?
Yeah.
Anything like emotionally, physically, financially, job plan wise, anything that you wish you'd known before you became a consultant?
I think it's the ownership of your decisions. So you kind of know about it, but I was thinking about it today. You do make decisions as a registrar, but you always know you've got you're conveying that decision because of what your consultants told you. It's not that often that you fully own a decision. And I think once you become a consultant, the decisions you make are your decisions. So you own those decisions. And that's probably one of the biggest things I think that plays on your mind as a new consultant. Even I remember sitting in clinic and I was finding it difficult to sign my name to something that I'd written in the notes.
Yeah.
Because I was like,
Yeah.
oh my God, when I signed this, that's me saying that no one's going to quite yes, obviously someone might question it, but that's me owning that decision. I can't go, oh, my consultant told me to do that, or my consultant advised me to do that. That is my decision. So I think it's that owning the decision and being kind of ready for
But
it.
how long did it take you to actually get around to the fact that this is it? This is the buck stops with me.
I think I'm
Not long, I'm guessing.
not long in certain aspects, but there's still things that I think you kind of go, oh my God, okay, this is really on me to do that. Like my first phone call on Monday night, it's fairly big decisions had to be made and I made them, but you're still then kind of going, oh my God, this is me making that decision. But I think that's where having colleagues has really helped, because actually just knowing that I've got colleagues that I can run those ones where I'm like, God, am I making the right decisions? Having someone that I can just get a second opinion on and just discuss with a colleague. And 99% of the time they've gone, yeah, you're absolutely making the right decision. But just having that bit of extra backup to when you're a new consultant to go, okay, yeah, my brain is thinking along those right lines, I'm making the right decision, has definitely helped.
So I guess being the first on call really is, you had quite a fair bit of time working as a consultant before starting your first on call.
Yeah.
I guess that's your first real moment of when that's you are literally the lead for it. So did you find yourself sufficiently well prepared for that? I guess you did.
Yeah, I think I did. Maybe because my last 5 months, I think, were at Adam Brooks, where because I'd been there before, I was given a lot more leeway in terms of a lot more responsibility. So running those on-calls at Adam Brooks, being the resident on-site senior reg, it's busy and you are dealing with a lot of complex things and managing a lot of complex situations on your own. And when the consultants trust you, they let you get on with a lot of it, and obviously just update them when you cut. So it
So
felt
why
like,
do they trust you? Do they just look at you and go, "I trust you"?
I think for me personally, it was because I'd been there before, so they knew I'd worked there before. They'd remembered me, and then when I came back, um,
Okay,
it
so
was
so
it
they
was
trust you because they're
it
familiar
was
with you.
familiarity as much as, I'm not saying I'm amazing. It was just, I think a lot of it was familiarity. And you can't help that. If you've worked with someone before and you know they're a sensible
Mm.
pair of hands, you inevitably trust them. Whereas it's human nature, isn't it? If you meet someone for the first time, it's hard to immediately take the reins off completely and let them have kind of carte
Okay,
blanche.
but what if you work with someone before and you don't completely, don't want to say trust them
Yeah.
100%, but you're kind of iffy about, yeah,
Yeah.
I met you last year and you were neither here nor there.
Yeah. Again,
What then?
I think I try very hard to again have blank slates, because I think I fundamentally, until people demonstrate a pattern, I fundamentally believe people can change, and people can be different on different days. People, someone who maybe had a difficult time 6 months ago or a year ago when they were there, that doesn't necessarily mean to me that they're still going to be the same when they come. So I do try very hard to give everyone a kind of blank slate, even if I've had, and you can't help but have preconceptions, it's human nature. But even if I've had preconceptions before, I try very hard to not hold on to those and just judge them on a kind of blank slate and go, okay, fine. We might have had a bad experience together before, but that was 6 months ago. Let's start fresh and let's see how we go. And then if it becomes a repeating pattern, then that's a different situation. But I do try very hard to give people a kind of fresh start and a kind of blank slate and go, okay, fine, whatever's happened, it's happened. Let's start again and see where we go from here. Because as trainees as
Okay,
well,
that
and
that that
you learn a lot in 6 months or a year or even 2 months. I think you can change a lot.
that makes me think I need to mess things up and then and then see if you can give me a blank slate
Blank
after
slate.
that. Right, finally, any last piece of advice you want to give our colleagues, ST5s, 7s, not just in anesthetics, but other specialties as well. Anyone who's in that position, let's say one piece of golden advice would be what?
I think it would be what I tried to do, which is forget the paperwork's the paperwork, and you will always get the paperwork done, but you have to feel you're going to be ready to do the thing that you're going to become the consultant in. So you have to mentally and physically feel that you're ready to do the job you're going to become the consultant in. You can get all of your sign-offs done, et cetera, and that's fine, but you still have to feel like you're ready to step into that role and be the decision maker and do those, if it's a procedural job you're going to be doing, to be able to do those procedures, you have to feel you can do that on your own, because it doesn't matter if you've got everything signed. If you don't feel that you've done enough and you're not ready, then you won't feel ready. And I think I found being a consultant more enjoyable because I made sure that in my last 6 months, I really tried hard to feel like I could do those things on my own and be ready. And I think that's the big difference. It's just you've got to feel like you're ready, not just have the paperwork done.
I think that is really good and brilliant advice, and I completely agree with you. So thank you very much again. You've ended with very, very, very wise words, and I will probably catch you again at some point to talk about your interview, and maybe in a few months' time when you've had first-hand experience of
Okay.
things gone
Wrong.
wrong and managed those things. We'll catch up and see how you manage them. So until then, thank you very much, Sahel.
No worries.